Hi, I think we're live and ready to get going. It's great to have everybody here. Dr. Tombal is our fearless leader. If you want to kick us off, Dr. Tombal.
Okay, so I'm very happy to be here with you. This will be the mid-year update on radiopharmaceutical in prostate cancer, as you understood already. Next slide. I'm not going to do that alone. I'm here basically just to listen to two very famous faculty, Pedro Barata from Case Western University in Cleveland, Ohio, and Alicia Morgans from Dana-Farber Cancer Institute in Boston, Massachusetts. Next. So what are we going to discuss? We're going to discuss indeed ASCO 2025 update. I'm going to speak a little bit about PSA and alkaline phosphatase decline in PEACE-3, the study comparing radium-223 to an enzalutamide to enzalutamide. Then we're going to speak about the initial efficacy and biomarker analysis of COMRADE, interesting study combining PARP inhibitor and radium-223. Then we're going to have an update on BULLSEYE with PSMA lutetium, and then some very interesting real-world data on mCRPC patient treated with PSMA lutetium, and finally, some actinium data that is probably the new kid on the block in radioligand. Next. So what about PEACE-3? It was recently published in Annals of Oncology. This is a phase 3 randomized trial in patients progressing on androgen deprivation therapy. We could include patients who had also received abiraterone, but there were very few patients. So primarily, this is first-line metastatic CRPC patient with bone metastasis. They had to have more than 2 bone metastases, asymptomatic or mildly symptomatic, randomized to receive radium-223 plus enzalutamide versus enzalutamide. The study was powered to detect difference in rPFS, but also OS as a secondary endpoint. Next. So we reported in Annals of Oncology a few days ago, the paper is actually out today, that the combination impacts PFS with a benefit of a little bit more than 3 months, but more interestingly, an important benefit on OS seen at the interim analysis only, so with only 80% of the events. And something very important we may discuss later on is this kind of specific relationship between PFS and OS. Usually in most trials, you've got a big benefit in PFS and a small one in OS. Here with radium, it's the opposite. The benefit in OS at this point in time is double the benefit of PFS, and that's probably highlight the mode of action of radium. Next slide. One of the comments people always had with radium is that it's very difficult to monitor because there is no major drop in PSA, sometimes drop in alkaline phosphatase. So I believe this PSA and alkaline phosphatase data are very interesting because what we look at actually is the speed at which PSA decreases. And so what we look at is the median time to confirm PSA response more than 90%, very aggressive in metastatic CRPC, and the confirmed alkaline phosphatase response at 6 months and 12 months. And actually you see that there is a major impact on the time to confirm PSA response. So basically, the PSA reach a low level much rapidly in the combination. And I really believe that this is the first time that a randomized control trial show a benefit in PSA endpoint with radium. So I believe this is important. And once again, strengthen the conclusion that the combination has some value in this group of patients. Next. We also look at the incidence of adverse event. You know that there were some worries with radium coming from the ERA-223 trial. When you hit the bone very well, if you don't protect the bone very well, you are exposed to an increased risk of fracture. What we see here is a very modest risk in the increase of fracture from 1.2 to 5.1%. But we made a bone-targeted agent obligatory. So I think that one of the characteristics of radium is that it's actually extremely well tolerated with very limited increase, less than 10% in grade 3, grade 5. And if you look actually at individual side effects, there is not a single one which is increased by more than 5%. So I think this is very rational. So this was the update of piece 3. I think that basically piece 3 is just a reminder that radium exists and that it's a drug that has its role in the care pathway of metastatic CRPC patients. So I think that now that we have piece 3, we should rediscuss the future of radium. It's strange to discuss the future of a drug 10 years after the launch, but I really believe that's what we should do next. And having said that, there is much more to come with radium. So Alicia, I think that we're going to discuss COMRADE.
Yes, and thank you. And it is interesting to be discussing radium again. And in this study, COMRADE, we saw another presentation. This was actually an oral abstract, so one of the big ones at ASCO this year. COMRADE was a phase 1/2 study of the combination of olaparib and radium-223 in patients with mCRPC who had bone metastases. Importantly, this was an unselected population, and we know that there has been a lot of focus on the treatment of patients with HRR mutations with PARP inhibitors like olaparib. So this was an all-comers type of a trial. Patients got into this study as long as they had mCRPC with at least 2 bone metastases and at least 1 that had not had prior radiation. And they could have adenopathy or lymph node involvement, but it had to be less than 4 centimeters. No prior radium exposure. They could have had prior chemotherapy. And just as we heard with the last study, bone protective agents were really important here and were a critical component of the design of this trial, I think, based on the ERA 223 study and, just our knowledge that patients with mCRPC really should be getting standard of care treatment with bone health agents. We can see in this schema that the phase 1 component of this trial was trying to understand the optimal dose of radium-223 and olaparib. And you can see that they then moved into the phase 2 component, which was designed to be olaparib 200 twice a day, which is a little different than the 300 BID dosing that we often use in patients with prostate cancer. The primary endpoint of the phase 2 part of this trial was radiographic progression-free survival, and you can see stratification factors listed there below. Crossover was allowed at radiographic progression, and then, of course, treatment per investigators' wishes for patients as they continue to follow for further endpoints like overall survival. Next slide, please. Here we can see the baseline characteristics of these 2 groups that are pretty well balanced. And remember, it's not a massive trial, but it's ultimately, they had about 120 patients that were randomized. There was some conversation around some challenges with randomization that ended up coming to pass within this study, but 120 ultimately randomized. You can also see that about 45% of patients had over 20 bone lesions on their bone scans. So this is going to be a population that has quite a burden of disease. And you can see the other characteristics, including Gleason score, measurable disease, prior chemotherapy listed here. Next slide, please. Here we can see just the breakdown, particularly looking at the HRR positive rate, which is about 19% to 26.5% between the 2 arms, with a BRCA positive rate in that combination arm being a little bit less numerically, at least, than in the radium arm, all assessed here by ctDNA. Next slide, please. And what we can see here is the radiographic progression-free survival, which, if we look at that top line, the IIT population is longer in the combination of the radium and olaparib versus radium alone, with the hazard ratio of 0.47. So this study did meet its primary endpoint of prolonging radiographic progression-free survival by adding olaparib to radium. If we look down at the subgroups, there's a general benefit associated with the addition of olaparib to radium until we get to those patients who had greater than 20 bone metastases who did not seem to have a clear benefit at all from the addition of olaparib there, with a hazard ratio of 1.17. So not below 1, actually right around 1, which suggests no benefit. And you can see other differences here. Numerically, some of these are actually very close despite the hazard ratios suggesting a statistical benefit. Next slide, please. I think importantly, though, when we look at other Other endpoints that are meaningful and things that were even discussed in the last study: time to next systemic therapy, similar; time to PSA progression, similar between groups; time to SSE, similar; overall survival, similar. So if we look at the overall survival over 18 months, 52, 55, potentially even numerically favoring radium. So, and the median overall survival actually quite similar between the groups. So no real difference in overall survival. Next slide, please. We can see that slightly different PSA responses in terms of decline of PSA and alk phos, but these are numerically slightly different, but I'm sure statistically they're quite similar between the groups. Next slide, please. And when we consider this in the context of the adverse events, which are, of course, greater when we add a PARP inhibitor to radium, we see that there are more adverse events to that combination, with more anemia, more overall grade 3s, more lymphocytes that are going to be lowered, more platelets, cytopenias in general. So this combination, I think, for an unselected population, I don't believe will necessarily move forward. However, I do think it's important and interesting, again, that we're talking about radium in combination in MCRPC once again in this meeting. Next slide, please.
Wonderful job, Alicia, and happy to be here as well. So just to highlight here, another study that was really emphasized during ASCO. Really a nice story. This trial is a BULLSEYE study presented by Dr. Privé. Actually, that's a nice story preceding. There's a clinical a CCR paper as a pilot study that led to this randomized phase 2 study. Also, the author got was recognized with an award within ASCO and the Cancer Foundation. And so, with that said, looking at this randomization for these patients with oligometastatic hormone-sensitive prostate cancer up to 5 lesions, we're looking at high-risk patients. PSA doubling time of less than 6 months. We'll see that in a minute. They screened almost 80 patients, but end up final analysis was about 58 who made it one of the two studies, one of the two cohorts, excuse me. One of them, 177 lutetium PSMA INT and or randomized to what was considered standard of care by the authors to FER ADT. What's relevant is 2 points. One, patients on the standard of care were allowed to receive lutetium PSMA upon progression. The endpoint of interest in this particular study is considered progression-free survival. Is defined as a 100% increase of PSA and or radiographic progression as well. As you can see, that we also have quality of life and response safety as other secondary endpoints of interest. So next slide. So here you can see who are these patients. Again, doubling times very short, lower than 4 months, which kind of reflects that high risk population we're referring to. You see that the vast majority of patients got prior local therapy, intention of cure. So these are patients with recurrent disease. And that's kind of aligned with the strategy from the authors on this randomization for this design. Next slide. So diving into the results of the study, I should have mentioned that design is 2 + 2, perhaps doses of 177 lutetium PSMA, and a big number of the patients end up receiving up to the 4 cycles. As you can see here, the median progression-free survival 5 months for the standard of care before ADT compared to not rich. This was statistically significant there in terms of a 0.07 of the hazard ratio there, less than 0.001, so statistically significant there. The present follow-up at time of the presentation was actually 27 months, so more than 2 years, and also a much shorter, a third of the patients with these follow-up progressing on lutetium cohort compared to almost everybody on the deferred ADT. You also can see there the decline, the PSA, the change favoring the treated patient with lutetium PSMA, and about 1 of 5 of patients getting a complete remission while on therapy. Next slide. So the other aspect is as we test this agent, this form of radioligand therapy with a beta particle earlier, there's always the question around safety, right? You can see that you see a lot of zeros or single digits as you look at the right side of the board, which reflects that for the most part, the very safety or the very benign or favorable safety profile as we assess it for common things or common adverse events. As we see, we do highlight some cytopenias, some dry mouth and fatigue. as some of the things that we're paying attention to when we're looking at particularly short-term adverse events for the most part. Next slide. So I'm going to pass the baton back to Alicia.
Thank you so much. And so continuing to talk about lutetium-177 PSMA 617, we also saw some real-world analysis of early adopters. And I think this is such interesting data, and we've seen some of this before. As the drug has been rolled out in the United States, and the indication has been actually somewhat restricted until relatively recently to patients who have mCRPC and have received treatment with docetaxel, as well as an AR pathway inhibitor. We've seen that in the United States, even before the label suggested that treatment prior to chemotherapy was going to be FDA approved and on label, there was a fair amount of utilization going on before chemotherapy. So this study was another of these real world analyses pulled from IQVIA data from treatment of patients between who were diagnosed with prostate cancer and were followed between 2013 and 2023. So certainly before the label was expanded to include the pre-chemotherapy data set. The index period was defined with the patient having their initiation date on lutetium-177 PSMA 617. That billing was the notable kind of index event. And then the index period extended prior to that, 12 months prior to that baseline. And then they had a variable follow-up after that to understand who these patients were and how their outcomes appeared. They included 643 patients. Next slide, please. What we can see here is that the median age of patients included in this real-world analysis was 69, so really consistent with our prostate cancer populations. Most patients had either one or two areas of metastases, with 90% of patients actually having those metastases in bone. 44%, though, did have visceral metastases. And they saw that about 46% received either an ARPI or a taxane prior to treatment, but not necessarily both. And I think that's interesting and really reflects sometimes the way that patients can have access to things even when it's not necessarily on label in the United States, which can be a pro or a con, can be challenging or beneficial to different practices, and we all interpret it in the way that that we see it. But in any event, the results are on the right. Overall survival in the study was a median OS of 15.3 months, which was really consistent with that post-ARPI, post-taxane vision population that had been reported within the clinical trial. At the time of follow-up, 21.3% of patients had passed away. And they showed that even in subgroup analyses, treatment with lutetium-177 PSMA 617 really showed similar survival, regardless of the patient age, race, ethnicity, the number and type of metastatic site. So a consistent effect across all of those. And I will pass the baton back.
Thank you very much. And as we heard earlier by Dr. Tombal, indeed, we're having more data beyond lutetium PSMA, particularly with alpha particles, actinium. And so here, there's actually a public presentation that happened during the AUA of 2025, early this year. You're looking at the experience of the group. There's a Weill Cornell's experience with 225 actinium J591, which is an antibody against PSMA. And you have the experience there with 31 patients treated at their site, including patients from two studies or two clinical trials they enrolled patients to in the last few years. So this is a heavily treated population. All the patients progressed on prior RPI, the vast majority also chemotherapy exposed and progressors. And as you can see there, again, heavily treated patients, very high PSA 171 median baseline there. Also have 2/3 of the patients the Halabi risk stratification, which is one of the risk scores we use to assess independently associated with poor outcomes. So you can see there also by the sites of metastasis, this is a heavily treated late line setting. Next slide. What's interesting about this data is the promising efficacy signal we can appreciate here. With median overall survival touching 11 months for these 31 patients treated, the tumor control measured by radiographic progression-free survival over 10 months and a biochemical progression-free survival of 3 months suggests a signal there, activity of these actinium 591 post Pluvicto-treated patients. From the safety perspective, not really surprising. I think we're learning a lot more how to use these therapies as we are having them in different studies. We do see cytopenias, particularly with alpha particles. We do pay attention to the platelet number and the platelet count. So you can see there about a fourth of the patient getting significant thrombocytopenia. For the most part, if I remember correctly from looking at the details, the need for transfusion was extremely low. So these are basically cases where you actually monitor. In addition to that, you can appreciate some fatigue there, although in the single digits. So for the most part, we have very manageable toxicity here. And remember, keep in mind, these are patients who have received prior 177 lutetium. The question, obviously, for further development is whether or not we're going to understand if there's a role for a sequential use of radioligand therapy with different payloads, in this case with an alpha particle. Next slide. So from the summary of these two studies, I do think we see efficacy in this patient population heavily treated post-lutetium 177. There appears that the clinical factors we commonly use to assess disease and poor prognosis in metastatic castration-resistant disease seem to hold true in here, in particularly also associated with anemia. And finally, there's a multi-center study basically with an antibody 591 lutetium with a beta particle, not with the alpha, not with actinium, but in validating these findings. This is actually a study that is taking second ARPI or chemotherapy as a control, as standard of care, and is testing the addition of that particular agent 591 in addition to standard of care. So I think we'll find more answers in regards to these kind of questions. And with that, I think this is my last slide. So I'll pass it back to Dr. Tombal. Thank you.
Yes, thank you. Thank you. That was a very nice presentation. I have a few questions for you. So to me, I mean, when you look at PSMA lutetium, it's used earlier and earlier and earlier. We've been the release on the internet that PSMA addition has reached its primary endpoint. When do you think that, how do you see that drug in the future? Do you see it very early? Because keep in mind that in the PSMA-4 trial, there was no very significant benefit in OS, which to me, I look at whether you give it early or late, it doesn't change anything. So because that's really the question. Is it much better if you give it earlier? It's a radioligand, so if these patients live 10 years, we may have concern. Where do you see the future? Do you still see it as a vision, metastatic CRPC and ZAPI setting, or do you think that in the end, it's going to move earlier?
Go ahead
Both
first.
of you.
I'll take it next.
Ladies first. Always.
Yeah, thank you. This is not an easy question, Bertrand, and I think that the toxicity profile is one of the things that really is sort of driving behind this question, because I'm always trying to make sure that when I treat a patient, I'm doing the best thing in the moment, but I'm also not, causing potentially catastrophic complications down the road. I think that we're going to need to see the data from PSMA addition, and not just the safety data, but also the subgroup analyses and to understand which patients seem to be getting the most benefit. I do worry about patients when sometimes when we use the strategy to save something for a later line, we end up not actually having the opportunity to give patients all of their treatment options. And I do worry about that. And I know Pedro has thoughts around kind of ensuring that people get the best possible option up front to allow them to have that option at all. And I think that understanding subgroups of who might respond most effectively, most strongly will be one of the ways. And then, of course, the long-term safety data that we still need to see as well. And Pedro, I don't know if you want to comment.
Sure, I appreciate that. So I see it in 3 or 4 different aspects. It's a fantastic question. Where are we going to go from here? Are we going to keep moving it on? Earlier, as Alicia alluded to. So I agree. We have to see survival data. I don't think seeing tumor control in the form of rPFS will be enough, because the bar is higher in the form of overall survival, because it's a matter of when do you get it rather than if you get it or not. On top of that, I think the reason why it's available, even though we didn't see a survival advantage, is because of the favorable safety profile and tolerability, which makes it a very attractive option. On that particular study, MCRPC pre-chemo, you also have the aspect of delaying chemotherapy, and you're not doing that on top of anything else that's super active, as we know. Whereas in this setting, PSMA addition, we're actually offering a doublet that's very effective. So what we need to account for things like attrition. I don't think it's an easy step to start throwing the sink at every patient that comes to see us with metastatic disease. I mean, we've been over 7 years trying to show the data to the world about bringing ARPI on top of ADT, and still there's a significant number of patients not receiving what's considered a standard of care. So I think it's an additional obstacle to bring lutetium PSMA, assuming there's a survival advantage there. And finally, I think what might pan out down the line is if we understand who are the patients who truly might achieve these durable remissions, where perhaps you can think of things like treatment de-intensification or de-escalation by bringing lutetium PSMA up front, assuming that that is very positive. I think it's likely we're going to start understanding who of the pool of patients coming to see us with metastatic hormone-sensitive disease would be really great candidates for it, in a sense that we might think of things like intermittent therapy approaches. So I really think there's not a one-size-fits-all. I don't see us using for 100% for patients. Of course, we got to wait for the data, but it is true that the tolerability and the data developed in different settings does help the experience the providers have in the real world to use it more comfortably, and also helps to minimize the logistic challenges that sometimes still exist to accessing RLTs for patients with this disease.
But
yeah, go ahead, please.
Bertrand, I'm sorry. I just wanted to say that it does look like there, or at least the press release suggests that there's a trend at least towards improved overall survival.
Yeah, that's what we see. Yeah.
Which is important.
But another important question is, assuming you've got six cycle, is that it seems to me, and here it's like, I'm going to throw like a criticism to see how you react to that, is that it was actually designed as a chemotherapy, okay, with a fixed dose of administration, 6 cycle. In Belgium, we're very privileged. We had been using PSMA lutetium 617 for 5 years. Now many at the center have moved to, we have been using INT, and now most of us are moving to 617. But so having treated quite a few patients, we've seen some patients with sometimes heavy disease burden who have complete response after 3 cycles of PSMA lutetium. I mean, yeah. I just had a call this morning from my nuclear physicist who say, look, the guy is 82 years old. He had been on AB and he had been on ADT and AB for 7 years, not really fit for docetaxel, not in great shape. We give him 3 cycles of PSMA lutetium 617. The guy is like resuscitating. But then comes the question, what is the rationale to keep treating when the target is gone? Haven't we done, are we sure we've done the proper, you were speaking about de-escalation optimization trial. Have we done that? Should we think about not only who, but how much we should give in case of extreme response?
Alicia, go ahead.
Yeah, I mean, yes, absolutely. And I think that Novartis, as for lutetium 177 PSMA 617, they are designing adaptive trials to try to answer some of these questions. But so many other radioligands coming onto the market at some point in time, or at least trying to get in, I think would be very wise to consider this even as an upfront strategy.
Yeah, I agree with those comments. The answer to your question, Bertrand, is no. We have not done a good job yet. But to be fair, it's actually true. If we look at the drug development process, right? In general, we get therapies available to patients, and then usually academic studies try to optimize the delivery, the dosing, the schedule. We've seen this before, and I think that's what we're going to be seeing. Actually, in other RLT programs, there seems to be some kind of adaptive design already embedded in some of the studies, not all of them. So I really think we're going to end up seeing that with lutetium PSMA, but probably with other RLTs. It's a fantastic question. Optimization is needed. In the patient that you described, the common sense would say, let's hold off and see what happens, right? As I think you alluded to. I agree with you. I think there's room for us to learn more and understand exactly who needs what and how much.
Thank you so much, guys. Ladies, it was a fantastic discussion. I thank you for participating in this activity. It will be available online soon, and I hope you learned something from us. Please keep aware on Medscape Global Oncology channel, and we see you soon on this channel for more interesting discussion with us or many other key opinion leaders. Thank you so much. Have a good day, a good night, a good evening, whatever, wherever you are, and see you soon.
Bye-bye.
Thank you, everybody. Bye-bye.